Welcome, everyone. I am Donna Jacobs, and this is the Not All Wounds Are Visible series. This is one of two series offered by the community health team at the University of Maryland Medical System. The other one is about physical health, and it's called Let's Talk. Perhaps you've joined that before. And this one, of course, is about mental wellness. I will moderate this program today. Our Not All Wounds series focuses on mental and behavioral health issues, and our goals are three: to increase awareness and remove stigmas related to mental health, to help people get comfortable talking about mental health and addressing mental health issues. Often we want to sweep it under the curtain and don't address it, and the more they fester, the worse they may get. And then, of course, overall, just to improve mental wellness. We focus today on issues related to trauma, and here to speak to us in this conversation and to lead this conversation is my good friend and colleague, Bella Catalina Chant. Bella is a Master Degrees registered nurse at the R. Adams Cowley Shock Trauma Center at the University of Maryland Medical Center in Baltimore. She has over 10 years of nursing experience with a tremendous background as a bedside nurse caring for patients with spinal cord injuries and multi-system trauma, characteristic of the work at the Shock Trauma Center. In addition, she has a huge commitment to and a penchant for community health and the well-being of everyday citizens. She works closely with the community health improvement teams at the University of Maryland Medical Center and throughout the University of Maryland Medical System. She co-led the COVID-19 community vaccination effort for the medical center in Baltimore City, which I can tell you was a Herculean effort. And she works tirelessly to reduce barriers to care and promote trauma-informed systems of care, which is what brings us here and brings her here to speak with us today. Before I turn the program over to Bella, though, let me say a couple of housekeeping notes that bear repeating. This conversation is really meant to be a dialogue. It's not meant to be a lecture. So do feel free to put your questions in the Q&A box, not the chat, but the Q&A box where we can receive them. And Bella will be happy to address as many of those as is possible during our time. Please try to ask only general questions. Obviously, we won't be able to ask questions related to specific individual mental health concerns. And Bella, maybe with that, I can just turn over to you.
Thank you so much for that wonderful introduction, Donna. It really is my pleasure to be here today. And so while this was initially meant to kind of focus about different types of training and treatments for mental health, I really wanted to focus on trauma-informed care because I think that that's really the lens that we can approach this webinar with and really talk about the different trainings that are available. And so before we can even begin to talk about trauma-informed care, we need to talk about what trauma is. And so these are events or series of events or a set of circumstances that are experienced by an individual as physically or emotionally harmful. And so this can have adverse effects on the individual's functioning in all aspects of their well-being, whether that's physical, mental, social, emotional, or spiritual. And so these are usually unexpected and uncontrollable. And I would gather to say that, especially in the wake of COVID, we all have experienced something traumatic. When we start to get down to the issue of trauma-informed care, it really helps us to discuss how we can increase knowledge and awareness and promote resilience in the pathway to recovery. And so not only are we talking about what trauma is, but it's also helping to make sure that we focus on how can we be aware of all the different effects of trauma and really to empower ourselves and educate us about the adverse childhood experiences that can affect a person's well-being in the future. And so one of the things that we did see coming through COVID is something that's very remains with us today. A lot of times when we talk about healthcare problems, we're trying to get to the impact of what is wrong with the patient, what is wrong with them, why are they coming into the hospital, or what is making them not want to seek treatment. And so as Donna was stating, I did a lot of work with the mobile vaccination clinic. And so what we needed to do was change our model of thinking and trying to vaccinate everybody in these big, large stadiums or convention centers and figure out how do we reach people where they are. And so there was a lot of talk, especially when the COVID vaccine came out, and there was a lot of resistance to getting vaccinated. And so the problem was is that a lot of members of society that were still considering whether or not they wanted to be vaccinated, people just saw them as, conspiracy theorists or maybe uneducated, or maybe they were even selfish. And so unfortunately, that's not the lens that we need to be looking at this problem with. And so instead of asking what is wrong with the person or why they won't come in and get vaccinated, we need to talk about the reasons that they don't want to come in. What happened to them? What happened in their family? What is making them hesitate for just a moment before they agree to get that vaccine? And this is something that we can do in all aspects of healthcare, but also in our personal day-to-day interactions with our family and friends. And so now I wanted to talk about the different principles that help to guide trauma-informed care. And so the very first principle is realizing that trauma is literally everywhere. And so it is something that affects us. It affects all of us. It doesn't discriminate with regard to somebody's age or gender or even their racial background, but everybody does experience trauma to some effect. And so the lens that I like to look at trauma with is recognizing adverse childhood experiences. And so we have a whole extra webinar that's included in this wonderful series that talks about adverse childhood experiences. And so if you want to do a deeper dive into that, we'll have some links available at the end so you can explore that. But just to give everyone a brief background about ACEs, it was the largest behavioral study ever conducted by Dr. Folletti at Kaiser Permanente. And what they did is that they surveyed the childhood trauma experiences of over 17,000 patients with 10 questions. And so what they found out is that people who experience these difficult events in their childhood, the more experiences they have and the more negative experiences they have, the more likely they are to have a premature death. And so we aren't just talking about mental health, but kind of as Donna was alluding to earlier, everything that happens in mental health kind of bubbles over into our physical health as well. And so when we're talking in general about adverse childhood experiences, we're talking about three major categories. We're talking about abuse, neglect, and household dysfunction. And so when we talk about abuse, it's not just that physical abuse or somebody being, hit or injured every single day. We're talking about emotional abuse as well, or sexual abuse. But with regard to neglect, we're all very unfortunately aware of the different types of neglect, but also that it has to do with the people that surround us. So if we have parents or guardians that are incarcerated or have a problem with substance abuse, that can absolutely impact our ability to be a healthier individual in the future. And so part of this study has to do with that early adversity absolutely has some lasting impacts. And so if a person has a higher ACE score as they're younger, they can start to develop some other issues as they get older. And so we do see a lot of people come in through the trauma center that have traumatic brain injury or multiple fractures and burns, or people can just present with different experiences with depression and anxiety and suicide. And obviously HIV and AIDS, cancer, diabetes, and alcohol abuse. But also at its very core, if somebody has a lot of difficulties as a child or experiences these adverse events, they can have difficulty progressing in their education or having a meaningful job or earning a large enough income for them. And this is one of the things that really struck me about adverse childhood events. I think it's really important to see that it does hurt people, but I'm the type of person that needs to know, how bad is it really? And so this graph kind of shows you if we compare somebody who has 0 ACEs compared to somebody who has 4 or more ACEs, that person that has 4 or more ACEs is 2 times more likely to smoke or 2.5 times more likely to have a sexually transmitted infection. And so that really shows that crossover between mental health and physical health. And when we look at this graph, I think it's very clear to see that a lot of times when we talk about diseases of despair, this has a lot to do with whether or not that individual has experienced adverse childhood events in their childhood. And so particularly when we look at our community today, nationally, adults have at least one ACE score. About 62% of people have one ACE score. But when we talk about that cutoff between who has a large number of ACE scores and a less number of ACE scores, only about a quarter of people nationally have 3 or more ACEs. But when we compare that to a place like Baltimore City, nearly a third of people in Baltimore City are adults that present with 3 or more ACEs. So perhaps they had a parent who was incarcerated, or they experienced physical or sexual abuse as a child. That's only 2 of them, and we're talking about a third of our adults in Baltimore City that have experienced some traumatic events like that. The second principle that I wanted to discuss with trauma-informed care is how do we recognize the signs and the symptoms of trauma? And that really brings us to one of the different types of trainings that we are trying to spread throughout the medical system, and that is mental health first aid. And so mental health first aid is not just something that we use for clinicians. It's really a public education national certificate course. And so it's important for all participants to learn to recognize and respond to those signs and symptoms of an emergent mental health problem or crisis. And so without going into too much detail, I did want to outline some of the action plan steps that are important in addressing different types of crisis and non-crisis situations. And so they like to use the analogy, or not analogy, but the letters algae to outline what those 5 steps are. And so that first step is to assess for risk of suicide or harm. And that's really, really important, because if somebody's going into crisis, you need to know how close that crisis is to occurring and determine whether or not you need to go into action quicker or if you had time. The second part of this action plan is to make sure that you're listening non-judgmentally, and that has to do with some of the trauma-informed care we were talking about earlier, that we need to make sure that there's a lens that this happens through. And so we can't start to characterize people as non-compliant. We can't characterize them as crazy. We need to just listen to them and hear what their perspective is. The third step of that action plan is to give reassurance and information, because sometimes people need more than just a listening ear. So we need to, one, acknowledge their feelings and let them know that they are safe, but also get them to the professional help they need. And that's where E, or that fourth step, comes in, where we encourage appropriate professional help. And so you can be certified in mental health first aid and not necessarily fix that person's problem in the end. You may not be the person that takes them to the hospital, but kind of encouraging to seek that professional help is an important step when somebody is struggling with a mental health crisis. And the final part of that 5-step action plan is to encourage self-help and to support other additional support strategies. Mental health first aid is something that tends to be divided into 2 different categories. And so we can focus on adult mental health first aid or youth mental health first aid. And that's the one that I'm certified in, because a lot of my activities at Shock Trauma have to do with approaching youth that are maybe making some poor decisions that lead them to be patients at Shock Trauma. But the adult mental health first aid course allows you to kind of focus or hone in on how do we deal with older adults? How do we deal with veterans in a different manner? Because some of the concerns that strike veterans, such as PTSD or what they used to call shell shock, are very different from what older adults may see. We also have higher education and public safety and fire and EMS, and we'll talk more about how mental health first aid can affect those individuals as well. The Mental Health First Aid Group of Maryland is part of the National Council for Mental Illness. And so they have their own website where you can actually sign up for courses, and they are still offering that program virtually and in a hybrid function as well. And so with regard to principle number 3, it's important for us to make sure that we are approaching mental illness and trauma with a fully integrated and an informed approach. And so that really talks about how do we support somebody who has experienced trauma? And this is something that we had to take into account when we were doing the mobile vaccination clinic. We couldn't just tell people to just go get vaccinated. What we needed to do was kind of recalibrate our language, because unfortunately a lot of providers, again, were saying that people didn't want to get vaccinated because they were stupid, or maybe they just don't pay attention to the news, or they aren't believing any of the research that's coming out. So we had to really change our model and really create space for people to allow them time to come to terms with whether or not getting vaccinated was something that they wanted to do, and also provide an environment that allowed them the space to make that choice. And so I'm just going to share very briefly a story that we had through the mobile vaccination clinic, is that I had a gentleman come up, and he was kind of angry that we were in his neighborhood. He's like, "Why are you trying to do this? Why are you trying to make us get vaccinated?" And I let him know, "Sir, we would love for you to get vaccinated. I firmly believe in vaccination, but I can recognize that that may not be something that you're willing to do yet. And so if you want to talk about it, if you'd like to talk to some of our providers or some people who have made that choice, we're happy to just give you that space and share a little bit about our perspective." But the second part of that was making sure that we were predictable. So we let him know, we will be here tomorrow if you wanted to come back. When we were at Mundaman Mall, we had a very predictable schedule where we were open 6 to 7 days a week from 11 o'clock in the morning until 6 o'clock at night. So whenever somebody did want to just walk in to come in and get vaccinated, they could, and there weren't any barriers for them to be able to do that. And again, when we talk about how do we change our language, we really need to talk about those labels that we use. A lot of times we tell people, like I said, "You're crazy," but what that gentleman needed to hear in that moment is that it absolutely made sense for him to not want to jump in and get vaccinated with something that had only been approved, or in his mind had been studied for 3 months. And so creating that space, I can't even express how important that was. And, instead of being prescriptive about how we treat COVID, we wanted to give them a choice. Even if you choose not to get vaccinated, here's a mask so you can help protect yourself and loved ones. And also recognizing that we as healthcare providers, or even we as well-intentioned neighbors, can't be the expert in everyone's lives. But what we can do is be an enlightened witness. We can say, this is why I made this decision. And so maybe that's something that you can consider as well. And the last principle that I really wanted to hone in on was, how do we resist re-traumatization? Because unfortunately, when we talk about trauma, it's very easy to re-traumatize a person. And that's the basis of trauma-informed care. Not only how do we help this person heal from previous trauma, but how do we make that individual more resilient so that they can, if they need to, face trauma again, or how do we protect them from having a negative effect to a traumatic event? And so trauma absolutely shapes a person's belief about themselves and others, and it affects their ability to hope, and it changes their outlook on life. And so some of the things that we do in the healthcare system, or some things that we can do even just as a well-intentioned neighbor, we can minimize that person or treat them as a number, or having to ask them 20 times, "Well, why do you not want to get vaccinated? Didn't you see the news report?" And so what that does is it makes that person feel like they are not being seen or heard. And so we need to kind of foster this trusting relationship. And so again, when we talk about people being non-compliant, or when we talk about people being, you're all about conspiracies, that doesn't take into account, and it demeans some of their very, very real fears about what's going on. The other thing when we talk about adverse childhood experiences is that we can't neglect that this person exists as as an individual, but also as an individual in a much larger community. And so there are adverse community environments that we deal with every single day. You know, when we talk about people that are, living in various states of poverty or, may be in between households, or if we talk about people that are unfortunately victims of violence, we have to recognize that this doesn't happen in a bubble. And so we need to kind of broaden our perspective, not only to how does that individual, how have they been a victim of trauma in their family, but also what else is going on out there in the world that may have created an additional barrier for them to succeed as an older adult. And I think I would absolutely be remiss in not talking about, the elephant in the room, especially when we talk about COVID. There is a long history and of mistrust with medicine. And a lot of it did have to go with the Tuskegee Airmen and in that experiment. And I just see that as such a huge parallel. And this was the parallel that the gentleman that came up to me in Edmondson, why he didn't want to get vaccinated. He's just like, the last time they did this, they literally lined people up and said, yes, we're going to give you a vaccine and we're going to make you all better. But what they did was actually doing research studies and never treated the person in the first place. And so he had a very real fear that that's what we were trying to do in his community. And so I acknowledged that with him and said, you know what, sir, if I had to live through that experience too, I would absolutely be wary of getting this vaccine. But here are the clinicians, here are the people that, are not just doing this to get their name in the books or be on TV. These are people that live in your community that absolutely believe in this vaccine. And if, we can help answer any of your questions, we're willing to do that as well. And so I think after we gave him some space, he was literally there the very next day and he brought his own father with him to get the vaccine because he was able to own some of that choice. And so, of course, with Henrietta Lacks, that's very, very prevalent here in Baltimore. And so she was very, very sick when she came into the hospital. And so instead of taking her cells and, trying to make her better, unfortunately, those cells were then developed to go ahead and help to accelerate cancer research. And she was never acknowledged for her contribution. And so she's very much regarded as a mother of modern medicine. But I think it also speaks to some of the history that we have to deal with every single day, not only in Baltimore, but in the entire state of Maryland, because this is very real. This is very fresh in a lot of people's memories. And so one of the reasons that we wanted to do this presentation is that we want to encourage everybody to develop a higher standard of care. When we talk about universal precautions in the hospital, we talk about making sure that we are washing our hands thoroughly because you never quite know what disease a person may have. You never know if you're going to expose yourself to HIV or maybe hepatitis. And so we need to just treat everybody the same and wash your hands regardless of what that person is coming in with. And so what that does is it helps create a safer healthcare environment for ourselves, but also for our patients. And so my goal through this presentation was to really encourage all of us to develop a higher standard of care, having a universal precaution with everyone that we interact with on our day-to-day basis, and provide tender, loving care with trauma-informed care, because I truly believe that if we approach people with a different lens, we would be such a better place. We would be such a wonderful environment and we would be a much better society. But I also think that if we pay attention to the trauma in the individuals that we meet day to day, we may get a better understanding of what happened to them, but maybe we can also start to recognize what some of those signs and symptoms of trauma may exist in ourselves. And that's where the last piece of the training that we want to encourage everyone to do is vicarious trauma training. And so not only do we want to support other people who have experienced trauma, but we need to recognize that some of the trauma that we may be seeing day to day can absolutely have an impact on how we live our day-to-day life. And so we need to treat ourselves with the same precautions that we would others, give ourselves space, provide ourselves some choice, and recalibrate how we talk to ourselves. And so vicarious trauma training is sometimes referred to as secondary traumatic stress or compassion fatigue or critical incident stress. And so vicarious traumatization is really just a negative reaction to a trauma exposure. And it includes a range of psychosocial symptoms that providers and responders may experience after seeing people literally on the worst day of their lives. And so the question is, who can actually be affected by vicarious trauma? It's all of us, anybody that works with survivors of trauma and violence. And I would honestly say anybody that's had to live through COVID. We've had to go through a lot in these past 2 years, and we need to recognize that. But specifically for people that are in victim services or working with, kids that are in the foster care system or EMS that are literally saving lives, right, in our communities or fire services or law enforcement. Like I said, they have to see people on the worst day of their life every single time, and it's important for them to make sure that they recognize that and look out for themselves. But beyond the idea of vicarious trauma training, we can't just say, just make sure you take care of yourself. We can't just check that box and say, well, go ahead and decompress when you get home. We need to recognize that this isn't just something that we do as individuals, but we need to make sure that we elevate it to it being the responsibility of our professional organization and our employees to create an environment that is informed by trauma-informed practices and vicarious trauma training. And so vicarious trauma training, they have a whole compendium or organizational readiness guide that helps us to look at our own organizations to assess whether or not we are able to support our employees' work and properly respond to trauma. And so not only is it about staff health and wellness, it's really how do we create that bigger environment from the top down? How do we make sure that our leadership is paying attention to promoting vicarious trauma training and trauma-informed care and really making that an integral part of our mission? And how do we do that to empower employees to speak up for themselves? And how do we give them the resources they need to be successful? And so with that, what I really wanted to wrap this up with is this quote that I came across a couple of weeks ago. And so this is very, very true today. And so a wise response to the viral pandemic or to COVID was that we closed ourselves off until a vaccine became more widely available. But what we need to do now that we're facing a trauma pandemic is that we need to become more open so that we ourselves become that vaccine. How do we empower ourselves and then in turn, get that cross-herd immunity that we were talking so greatly of when we were talking about vaccination? How do we do that to protect all people, whether it's in a clinical setting or at home, to make them resistant and more resilient to the trauma pandemic that's unfortunately facing all of us today? And so with that, I was going to go ahead and transfer it back over to Donna Jacobs, and we are happy to answer any questions that you may have.
Bella, thank you so much. That was tremendous. What a font of information. I'm sure all of our viewers really appreciate it. And every time I hear one of these presentations, I too learn a little bit more. So I've got a first question here that says, do I have this right? And I want to just do it for clarity.
Mm-hmm.
The forms or the methodologies for treating trauma, I think, sounded like we're in 3 parts. That's what this person says. Mental health first aid, trauma-informed care, and vicarious trauma. Correct?
Correct.
Okay. And so, go ahead.
Oh, sure. So, but I would say that trauma-informed care is that larger umbrella that mental health first aid and vicarious trauma training can obviously fit into.
Okay. So an umbrella and then 2. And I would say for our listeners as well that we will have additional sessions over the next few months. We may wait until toward the end of summer because people are traveling to talk specifically about mental health first aid and vicarious trauma, each in a separate session. So stay tuned for that. And if you've received notification about today, you'll get notification about that as well. Another question someone asked is, how do I get connected to mental health first aid? I've heard about it before. How do I find the class? Where do I go?
Sure. So what I would suggest people do, and so this is one of the things that I did, is I just typed in mental health first aid into my Google browser and searched for Maryland. And so there are classes all over the state, and especially the national classes you can take virtually. And so you don't necessarily have to be looking at classes that are only in the state of Maryland. So it's a wonderful certification process. I think it's incredibly worthwhile, and it's something that we can use every single day.
Great. And then another question, this might be the last one that I see here, is many of the references were from your experience or the experience of colleagues of yours in hospitals and hospital settings or healthcare settings. How do I, as a community member, get involved with trauma-informed care? How do I become even more aware, and what do I do as an individual?
Absolutely. I think that one of the best ways for us to be empowered as neighbors is to see how our language may be impacting how we deal with people. And so, yes, I definitely made a lot of references to working at shock trauma, and that's unfortunately because we see a lot of that every single day. So it's very fresh in my mind, but I think we can all look around in the world and see that there's a lot of trauma going on. And so it's not just something that's limited to a clinical setting. We need to make sure that we're looking for people that may be experiencing trauma at the grocery store. And so if somebody is walking around and they seem to be kind of overwhelmed, not being like, oh my goodness, that person's just crazy, being like, that person has a bigger story behind them. And what could possibly be going on in that person's life that is leading them to act in this moment? And if there's a way that you can help, absolutely. And maybe that's where mental health first aid comes in. Because like I said, that's not limited to just clinicians. Thank you for that really good question.
You make such a good point, and you hear people say it often, but it is very true. Everyone has a story, right? Everyone comes to the table or work or what play or whatever it is every day with a story behind them, and you may not know what that is. And so you describe the person who at the grocery store may seem troubled, but oftentimes, and we've seen this from some of the news media related to celebrities, people seemingly the most funny and the most at ease or traveling the world the most, maybe the most troubled. So your words were before, be kind and be understanding, be a listening ear, ever so important, because you never know what someone's story is and what they're dealing with behind that facade.
Absolutely. And I think one of the things I heard at a conference recently is we have to be careful not to judge people on their worst day, because none of us are as bad as our worst day, in the same way that none of us are as good as our best day all the time. Like, it simply isn't sustainable. So we need to make sure that we, provide people a little bit of grace.
Perfect way to end. Thank you so much. So for everyone, we said this at the very beginning, you can see this, it was recorded today, and the webinar will be available, conversation will be available in about 48 hours. You can go to the site that's there, ums.org/community/conversations. It's actually one of several ways to get to these. There you can look at all of the prior sessions that we've had in our Not All Wounds series, and they're listed there below. Bella mentioned the adverse childhood experiences. There's been one on suicide prevention and more. At that point, you can also see the slides that she has mentioned. So I say that the next webinar may be in August. It may be slightly later than that because, again, people are traveling and summers are sometimes difficult. But we invite you to look at any of that. They'll also, in July, we will have a series in Not All Wounds on dealing and staying mentally well in a time of constant and consistent crisis. There's a lot going on that we're all suffering through. COVID is one of many. Inflation, higher gas prices, job losses, political strife, war in Ukraine, on and on and on. And so we'll have a panel of 3 talking about how to stay mentally well when there are crises all around us, seemingly increasingly every day. And so Thank you, Bella, very much for a very informative talk, and appreciate the umbrella that you gave us on trauma-informed care and mental health first aid and vicarious trauma as subsets of that. Stay tuned all, and thank you for joining us today. Have a great day and weekend, holiday weekend.